across the country. So today, the topic will be on clinical management and contract tracing. We know that there is no cure for COVID-19, of course, but there's a lot that can be done with regards to supportive treatment and also managing complications. So we look forward to the presentation on that. And also, there's been a lot of interest lately on community testing. And we all know that the ministry has switched from indiscriminate to targeted community testing. And with regards to that, of course, the issue of contact tracing is very relevant. So we also look forward to that session. Just a few practical information before we start. This webinar is co-organized by the Ministry of Health, by University of Botswana, Botswana-Harvard Partnership, and Rutgers University. Those who would like to join can email directly at rmumakwa@yahoo.com to be able to join the webinars also later. Please be reminded to mute your microphones to avoid a lot of echoing. And a lot of questions that can be posted can be done so using the chat function like it has functioned in the past. This has turned out to work out well, and we have a co-moderator who will be monitoring those questions as the session continues. Other questions have also arrived before the session started, and they've been sent to the presenters. So most of those will be covered during the presentations, and some will be covered after the presentations are done. Please be reminded that the session will also be recorded today, and that a survey will be sent to you through email afterwards. Without wasting more time, I would like to get started by introducing our first speaker. It is a great pleasure to introduce Dr. Tommy Palai, who is a colleague at our Department of Internal Medicine at Princess Marina. He's a consultant physician and has research interest also in HIV and non-communicable diseases like obstructive lung disease. He has also subspecialty interest area in respiratory medicine. So Dr. Palai, floor is yours.
Good afternoon. It's good to be part of this webinar. Like Dr. Thusego said, we're going to be talking about clinical management today. Next slide. So obviously, over the last 2 weeks, we've gone through other aspects of the guidelines, which included how COVID-19 presents. We've also gone through other aspects, but today we're going to basically focus on clinical management. Next slide. So most of us already know how COVID-19 presents, but I just thought we should just remind ourselves. This slide is very important. We know that from evidence that 90% of cases actually present with fever, and this is data coming out of China and America. The next few signs and symptoms, including cough, fatigue, sputum production, and shortness of breath, are also important in trying to isolate or identify patients with COVID-19. One interesting thing that I found when researching is that anosmia, or loss of taste or smell, actually predicts patients with COVID-19. And in an evidence-based study that was done in King's College in London, it actually showed that about 60% of patients versus 19% actually test positive as opposed to negative, which means in a third of patients, anosmia actually predicts COVID-19. Next slide, please. Next slide, thanks. So it's very important when we have previous slide. It's very important when we suspect that patients may have COVID-19 that we quickly triage them, and during that triage, a severity assessment is essential so that we know exactly where and how to manage these cases. Now, mild cases can be managed outside of hospitals in isolation facilities that have already been identified by Ministry of Health and Wellness, and these will be communicated within all the districts in Botswana. But cases that are triaged as moderate to severe need to be admitted in designated hospitals. We know that Segitumila Masira has been designated in Gaborone, for example. And out of the cases that we will see, we know that 10 to 15% of mild cases may worsen over the course of the week. So it's very important that these cases are actually monitored. And this is usually done by our public health team and DHMT. And the decision will need to be made in the absence of test results, which may take about 48 hours or longer. Next slide. So the criteria for mild disease is of the following: saturation of more than 95%, a respiratory rate of less than 25, heart rate of less than 120 beats per minute, a temperature of 36 to 39, and a patient presenting with normal mentation. So these patients actually can be safely isolated at home or at facilities that are identified with Ministry of Health and Wellness. At the moment, actually, Ministry of Health and Wellness has identified either hotels or hostels, and if you are within a district, you need to contact your local DHM team to find out where exactly these patients can be kept, as opposed to have mentioned for patients with severe disease. Now, these are patients who are not at risk of deterioration. So these are patients that are less than 50, patients that don't have comorbidities, for example, heart failure, post-TB bronchiectasis, cancer, patients on chemotherapy, pregnant women, as well as children. All the other patients are considered to be high risk. Next slide. So once these patients have been identified and they are being investigated, we need to do a full blood count. And in patients that are usually confirmed with COVID-19, we find that they are lymphopenic or thrombocytopenic. They usually have multi-organ dysfunction, maybe mild to severe, may have acute kidney injury, they may exhibit transaminitis. Other bloods that are to be done include D-dimer, CRP, LDH, ferritin, which all may be raised. And unfortunately, in cases that have been identified with COVID-19, they prognosticate and are actually associated with poor outcomes. We know that about 21% of our population is HIV positive. So in patients who are HIV infected, we need to do an HIV CD4 and viral load as indicated. We also need to do a septic screen, which include blood cultures, chest X-ray, urine culture, as well as an arterial blood gas, especially for patients who may be hypoxemic. Next slide. We also need to always consider that there may be alternative diagnoses, and it's very important that we exclude these diagnoses. Throat swabs for the detection of viral and other atypical pathogens is very important. Sputum culture to ensure that there is no TB as a comorbid disorder is also important. We can send off for microscopy culture and sensitivity, as well as gene expert ultra, which we now have available. We can also send urine for Legionella antigen, as well as dipstick and culture, like I've mentioned. And an ECG also may help. Next slide. In terms of what we have found on chest X-ray, most of the patients that present with COVID-19 and usually are hypoxemic, you get chest X-ray findings that exhibit bilateral hazy peripheral opacities. Usually they are predominantly in the lower zones, but in this X-ray, they are distributed all throughout the lower, middle, and lung zones. And in patients that actually require ICU care. Next slide. This may eventually progress to acute respiratory distress syndrome, which is what this chest X-ray shows. And for COVID-19 patients, this can progress quickly from hours to days. So we need to be aware. In this X-ray, you can see that the haziness from the previous X-ray has actually worsened to even cause a blunting of the costophrenic angle on the left side, which suggests a pleural effusion. Next slide. It's important as well to do a CT scan of the chest, which obviously gives us more detail than a chest X-ray. And we found that in patients that have COVID, you get this pavy opacities within the lung parenchyma. And in this patient as well, there's evidence of bronchiectasis, which may suggest that they may have some underlying obstructive lung disease. Next slide. So in terms of managing these patients, oxygen is the single most effective supportive measure that we can offer our patients. And the WHO recommends that we start giving oxygen when the saturation falls below 90% in adults and below 92% in children and all pregnant women. And once we start oxygen, we aim for a saturation of about 92 to 96. And we really don't want to oxygenate, as this is associated with harm. And we have to titrate oxygen using different oxygen delivery devices according to the target that we've aimed for, which is 92 to 96. Next slide. So these are the oxygen delivery devices that I believe are available in most of the hospitals throughout Botswana. We have the nasal cannula, we have a simple face mask, and then we have a face mask with a reservoir bag. For nasal cannula, it offers an oxygen flow rate of about 1 liter to 5 liters a minute. So you want to start at about 5 liters a minute and monitor the saturation of the patient. If the patient remains hypoxemic, or if the saturations are not meeting expected demands, then we can then switch to a simple face mask, which offers an oxygen flow rate of about 6 to 10 liters a minute. And of course, if that still doesn't give us our expected target, we can switch to a face mask with a reservoir bag, which of course we commonly use for our patients with pneumocystis jirovecii pneumonia. And this offers an oxygen flow rate of about 10 to 15 liters a minute. Next slide. Most of these patients will come in quite septic. They may be hypotensive and exhibit signs of shock. We will need to give them fluids. But from the evidence that we have to be conservative with our fluids. And as aggressive fluid resuscitation can lead to pulmonary edema. So we need to try to match our input with our output. So when we receive these patients and they are quite unwell, we need to have a urinary catheter inserted, and we need to monitor our fluid charts quite robustly. So for example, in shock, when we give about 250 to 500 mils of crystalloid fluid challenge, we have to observe in about 15 to 30 minutes to see what the fluid status of the patient is. And if the patient is still behind on fluids, we can continue to give fluids. However, if we feel that the patient is replete, then we just need to observe the vital signs and continue monitoring. Next slide. If we have given the patient IV fluids, for example, normal saline, and yet their blood pressure remains on the floor, and that we are not meeting the target mean arterial pressure of about 60 to 65, we can start vasopressors. but we need to ensure that the patients are fluid replete. If the patient has a central venous line, we can use that if there's monitoring and in ICU. If the patient is in the emergency room, we can use a straight leg test. Most of the emergency room physicians or anesthetists should be familiar with this test. And once we know that the patients are fluid replete, we can then activate and start using vasoactive agents. And the recommended one is norepinephrine as a first-line agent. And if it's unavailable, we can use epinephrine. Now, because we expect that we are likely to get patients with comorbidities and patients who may have ischemic heart disease or underlying cardiac dysfunction, we can think about adding dobutamine as an inotrope if we do not get the targeted mean arterial pressure of 60 to 65, despite using adequate doses of epinephrine or norepinephrine. Next slide. Going back to sepsis again, we always need to have a high index of clinical suspicion for this. Hence, antibiotics are recommended in most patients. We know that the majority of patients will usually present quite febrile. So while we wait blood cultures, urine cultures, and the likes, it's important that we treat empirically for suspected sepsis or confirmed pneumonia, ideally with coamoxiclav at 1.2 grams 3 times a day for 7 days, and azithromycin 500 milligrams once a day for 7 days. Depending on where we are within the country, other alternative options are ceftriaxone and cefotaxime. We also have the option to de-escalate if patients do get better with oral cefpodoxime, which actually has very good oral bioavailability. Next slide. In terms of specific therapies in supporting patients, we have to give thromboprophylaxis unless it's contraindicated. This guideline is currently being developed. It's recommended that we don't give steroids unless we think there's a good reason to do that. Of course, we do get a lot of patients coming in with PCP or PJP, and these patients, if they present with hypoxemia and quite ill, they need high-dose cotrimoxazole and steroids. So in cases where you have a high index of clinical suspicion that you're dealing with PCP, steroids may be indicated. You may consider giving blood transfusion if the HB is less than 7, but targeting a higher threshold does not lead to better outcomes in sepsis. Now, we know that there's no treatment for COVID-19 at the moment, and this has not been proven in any trial at the moment. So our recommendation is that we do not give hydroxychloroquine or chloroquine unless the guideline changes otherwise. But we do not give this as we don't have any evidence that hydroxychloroquine or chloroquine do work. If there's any doubt, you can always call your local specialist. Next slide. In terms of patients that may present with severe COVID-19 or are critically ill, they may initially require high flow rates of oxygen or be intubated and ventilated. However, in the data that is now being published in different countries, there is this concept of prone positioning for patients that are non-intubated, actually. So this is just patients just lying on their tummies as opposed to being supine. And the data that is coming out of Beth Israel in the United States is that this may help or delay patients requiring intubation. And the physiology behind that is basically, one, in patients presenting with hypoxemic respiratory failure, is that it helps in better matching of ventilation to perfusion within the lungs. And secondly, it helps in areas of the lungs with re-recruitment and in areas of the lungs when patients are supine as opposed to if they were prone. So all this actually improves oxygenation and hence decreases the chances that patients will be intubated. This is all just observational data, and there's no published data to say that this actually works for COVID-19. Next slide. If patients do get worse while admitted in your facilities, and this is worsening oxygenation, saturations, patients that are sicker, you really need to quickly think about calling an ICU physician or anesthetist to intubate in a timely manner. Remember that we are trying to avoid aerosolization of these COVID-19 droplets. So we would rather intubate earlier rather than later. In other words, we don't want to intubate under pressure. So these patients are quite high risk. So for us healthcare workers, we would want to do the intubation in a timely manner. We will organize a specific session on ICU and an intubation at a later date to be announced. Next slide. For test results, if a test result comes out positive, we need to immediately transfer to a COVID-19 cohort area that's been designated within the district by the Ministry of Health and Wellness. For patients that test negative, remember that you know, it may take anywhere between 2 to 14 days, even longer, for a patient to shed virus. So if that diagnosis remains the most likely, please do repeat the test and keep that patient quarantined. However, if we've reached an alternative diagnosis, please, there's no need to repeat the test, and especially if the patient is improving. Next slide. In terms of discharging patients with suspected COVID-19 who have tested negative, these patients can be discharged provided the following criteria are met. 1, the fever is resolved. 2, their symptoms are improving. And 3, there's no other indication for admission as seen by the doctor in charge. And after the discharge, those patients are remain in isolation for a further 14 days, regardless of that length of admission. And this is because they are now likely a contact of COVID-19. So we want to keep this contained as long as possible. Next slide. In terms of discharge now of confirmed cases, so for these patients, they can be discharged from the hospital once the fever is resolved, symptoms are improving, and there's no indication for admission. And after they've been discharged, they're to remain isolated for a further 14 days. And this is also regardless of the length of admission during their stay at a designated Ministry of Health and Wellness facility. Next slide. And then in terms of the guidance to test when to de-isolate, the current practice at Sekiti Masira Hospital is that you need 2 upper respiratory tract samples that are negative for SARS-CoV-2 collected 24 hours apart. And the guideline is different for patients that came in with symptoms and those that were asymptomatic. For symptomatic patients, we must wait for at least 7 days after the onset of symptoms and 3 days after the resolution of symptoms before we can do the swab to de-isolate. And for asymptomatic patients, we have to wait for a minimum of 14 days after the positive test. Next slide. So I just thought I should finish off with a topic on the investigational and repurposed therapies. I'm sure for quite a lot of us, it's been circulating around, and a lot of countries are talking about it. I'm just going to concentrate on drugs that I believe we may have access to. Now, I repeat again, there is no proven data to say that any of these therapies work. I'll start off with Aluvia, or rather Lopinavir and boosted darunavir. For us, we have Aluvia, which is a ritonavir boosted lopinavir. Now, it inhibits 3 chymotrypsin-like protease. Now, it was actually trialed before for SARS-CoV-1 and MERS in 2012, and it did not show any significant statistic difference. Hence, we do not recommend just as yet for it to be used. This goes for hydroxychloroquine, okay? Now, in terms of the proposed mechanism, it inhibits viral entry and endocytosis by multiple mechanisms. But in terms of the data that has been published, nothing has been proven that it works. In fact, it's more the side effects that we are concerned about. It causes QT prolongation and cardiac arrest, and it's actually been reported in several countries that healthcare workers that actually tried to take this prophylactically have actually died, unfortunately. Okay, there's other therapies that are being trialed around the world, and it's going to be interesting over the next couple of weeks to months to see what comes out of observational data. But as of now, unfortunately, we have nothing in terms of a proven cure. Next slide. I believe that's my last slide. Okay, thank you.
Thank you very much, Dr. Palai, for such a wonderful, detailed presentation. We now have the tools to deal with sicker patients of COVID-19 when they get admitted and have a clear way of handling them if they even get worse. And as you emphasized, no cure, but still a lot that can be done to support them. Thank you. And this brings us now to the next speaker, Dr. Chidzani Mbenge, who will talk to us actually about contact tracing, something that she has personal experience with. Dr. Mbenge is a public health medicine resident at the University of Botswana and a 2019 Mandela Washington Fellow. She's currently serving in the COVID-19 Ministry of Health Response Team as one of the 6 members of the National Contact Tracing Team. So we're excited to hear more details about this. Thank you.
Thank you, Doc. Good afternoon, everyone. Like I've already been introduced, I'm Dr. Mbenge, and I'll be taking you through the contact tracing process as we've been conducting it since from the very, very first case that has been confirmed in Botswana. Next slide. So what is the purpose of contact tracing? I would like to say contact tracing is one of the critical interventions that are needed to contain an infectious disease like COVID-19. So the purpose of contact tracing is to rapidly identify and quarantine individuals that are exposed to COVID-19. This is in order to close down chains of transmission of COVID-19 in Botswana. This will also slow the progress of the COVID-19 epidemic in Botswana, and then we'll be able to avoid overburdening the health system, because as we close down the chains of transmission, then we don't have a lot of cases that are propping up because of exposed individuals that were never identified. Next slide. Because I was talking about the chains of transmission of COVID-19, let me talk about the basic reproductive number for this COVID-19. So a basic reproductive number, this is the number of susceptible individuals that will get the disease if they're exposed to an infected person. Literature tells us it's almost about 2.68, which I can say one individual can infect an average of 3 susceptible individuals. Next slide. So because I'm going to talk about contact tracing, I can take you back to the last cases that were identified in Botswana and just give you an example how we have been able to do the contact tracing to identify the cases that, especially the local cases that have been reported. on the 18th of this month, we reported 5 new confirmed cases, 2 of which were imported cases, and then 3 were local cases. So from these 3 local cases, they date back to the first ever imported case, and not the first ever imported case, to the first local transmission that we had. So this is an individual who had contact with some of his friends when he came into the country. So, and then 2 of those friends, they happened to work at the same workplace. So as we're confirming the work, these cases, we had to trace back all the places that all of these individuals have been. That's when we discovered that 2 of these individuals works at the same workplace. So we contact traced their families, their friends. Next slide. So just to take you through the process of contact tracing as we've been doing it, the first step involves contact identification and classification. Second step, contact listing. The third step, contact follow-up. And then the last, or not least of the step, contact discharge. Next slide. So going through the first step of contact identification and classification. So we have to define what a contact of a COVID-19 case is. So these definitions, we're able to adopt them from the WHO, from this CDC guidance, and also from the European Union Public Health Management of Contact Guidance. So a contact of a COVID-19 case is any person who had contact with a COVID-19 case within a time frame ranging from 2 days before the onset of symptoms of the case to 14 days after the onset of the symptoms. This is for symptomatic patients. And then for asymptomatic cases, a contact, sorry. Repeat it? Okay, I'll repeat the definitions again. A contact of a COVID-19 case is any person who had contact with a COVID-19 case within a time frame ranging from 2 days before the onset of symptoms to 14 days after the onset of symptoms. This is basically for a symptomatic case. However, we often get a lot of asymptomatic cases as well. So for asymptomatic cases, a contact person is defined as someone who had contact with a case within a time frame ranging from 2 days before the sample was taken that led to the confirmation of the case, or up to 14 days after the sample was taken. So with the second one, for asymptomatic cases, we often have had difficulty applying that one. So what we'll do is we'll risk assess and then go as far as 7 days to as far as 2 weeks after, before the sample was collected, in order to try to really find, to find the whole trace of that particular individual. Because like you'll find, if you followed up some of our cases, we have not been able to find out the source of their infection. Okay, next slide. So if we are able to identify whoever has been exposed to the COVID-19 case, then we should classify that individual. We classify them into close contacts and then into casual contacts. So who is classified as a close contact? Any individual who has been interacting with an identified case. This is an individual who would have had face-to-face interaction within 1 meter for 15 minutes or more. And then also anybody who's had direct physical contact with a case, or anyone providing direct medical care without or not properly using appropriate PPE. Also, any individual within a closed environment. This can be a household, a classroom, a meeting room, a hospital waiting room. This is for more than 15 minutes. Those people will be classified as close contacts. Also, anybody who was present during an aerosol generating procedure and they were not wearing the appropriate PPE. Of course, we don't expect individuals to be in an environment where we are generating, where we are conducting aerosol generating procedures, and they don't have PPE. But sometimes maybe you have a cleaner, I don't know how, coming into a room when you are doing that procedure, then that person should be classified as a close contact. We've had many of our cases being imported cases. This means that they had flown through the airport. They've come into the country through an aeroplane. So if it's an aircraft, we looked at any individual who was sitting 2 seats. We didn't really use 2 seats. We ended up using 2 rows. Here it says 2 seats. So we look at any individual who was sitting 2 rows in front and then 2 rows at the back, and then the whole row that he was sitting. So we classify all of those people as close contacts. And then anybody who was a travel companion who was returning into the country with that person. As you know, we have one of the confirmed cases. Some of the confirmed cases come from a cohort of 10 who had traveled together. So all of them will be close contacts of each other. Also, crew members who were serving in that cabin of the aircraft will also be considered close contacts. And then why use a casual contact? A person who had face-to-face, I can see the, sorry. That's fine. So anybody who's had face-to-face interaction with a case, but this is just within 2 meters and also just casually for less than 15 minutes. And anybody who's been in a closed environment with a case, but for less than 15 minutes as well. Or a healthcare worker or other person wearing the recommended PPE. For the healthcare workers, we really classify them as casual contact, especially when they're dealing with isolation areas, and then they'll be wearing the appropriate PPE, because we want to keep a surveillance of all the healthcare workers who have been in touch with all of our cases, so that in case they get sick, we're able to track any occupational exposure and any occupational cases that can arise. Also, returning travelers from highly affected countries are also classified as casual contacts, because you don't know from the countries that they're coming from who have they interacted with, they could have been exposed and got infected. You never know. So that's why the country, when the point of entry screening started, we were doing the home quarantining of this casual contacts, and as of 24 March, we ended up doing the mandatory quarantining of this casual contacts who were returning travelers from highly affected countries. So the bottom box there is in terms of what sort of management do we apply for our contacts. I would like to put a disclaimer that the epidemic is an evolving thing. So we always review these guidelines and try to see what's happening on the ground and how we can improve them. So what's been happening is, for all the previous guideline, if anybody had seen them, they were saying for close contacts, you are supposed to put them on home quarantine for the 14 days since the day of last exposure, and then they were tested at day 10. And then if you are not able to home quarantine them, that you then put them under facility quarantine. And then for casual contacts, they were doing self-monitoring for their symptoms and reporting to the hospital in case they developed symptoms, and they were not tested. So as of yesterday, when we were reviewing the guidelines at the ministry, a decision was taken to decide for facility quarantining of every individual that will be identified as a contact of whatever form. This is to maximize testing and also testing of any individual that has potentially, any individual that has been potentially exposed to the virus, and also as a form of actively finding cases among anybody who has been exposed. So I put a disclaimer there that this will be except for healthcare workers who are casual contact. Remember, I said healthcare workers who are wearing appropriate PPE they still have to be contact listed, but we cannot quarantine every healthcare worker who is working in an isolation area. As long as they were wearing appropriate PPE, they can continue working as usual. So also included in the management of contacts, you have to do active daily monitoring. So we have a daily monitoring tool that I will show. So as long as they're under facility quarantine, then they have to avoid unnecessary social contact and also practice all the other preventive measures. So I'll go to the algorithm, next slide, that will show further how we manage the contact. So before I go there, this is just an example of one of the contacts the section of the cabin of some of our confirmed cases that we were looking at. So we started with the numbering is the order in which the cases were confirmed. So we started only with one confirmed case at the time from this aeroplane. So what happens is, if we have a confirmed case who was a return traveler, we go to the particular airline and obtain the flight manifesto, and also look at the seating arrangement and map where everybody was seated. So we had one confirmed case. So we used the guideline to say anybody seated one row in front, one row at the back was going to be considered a close contact. And then everybody else was considered a casual contact. However, as the cases were arising from the same airline, because this is where the cohort of 10 was traveling from, we decided that everybody who was seated in this particular cabin should be classified as a close contact, and everybody there was considered that and quarantined and tested. So out of that, we still have only 6 who have tested positive. Next slide. So after you have, from the contact identification, how do we do the contact identification and classification? Normally, I'll give the experience with Gaborone DHMT because this is where we have worked really hand in hand with them. So if we get a confirmation of a case or a suspected case, before the case is even taken to Sekitimile Masire, we go to the fields, we go to the homestead and go do a history taking so that we are able to map and list all the contacts and look at the homestead, the compound setting, so that we are able to really map all of your contacts and classify them better as casual or as close contact. For cases that are really sick, then you might end up having to really do, you end up really having to do the contact listing at the hospital. I mean, contact tracing, it is part of case management, so we can never separate it from the two. Our contact listing form lists, it identifies the contact as the names, the age, what is the relation to the case? Is this a casual? Is this a close? And then where do they stay? The physical address, the town, the district, the phone number, and then we classify them if they're a healthcare worker, yes or no. And then also equally important is the date of the last contact with the case, because this will determine when the contact will get a testing. Next slide. So how do we do the contact follow-up? So this is monitoring for symptom development of the contact. It can be active or passive, depending on the risk and the resources. Remember when I was talking about management of the contact, I said we had to really change the guidelines because we were putting our contacts or those returning travelers from high-risk areas on home quarantine, but then you see that most of them were breaking the rules of home quarantine, and then that will end up in a disaster. So that is why the decision was taken to say everybody should be under facility quarantine and everybody should be actively monitored rather than doing the passive monitoring that can be done at home. So next slide. So this is the algorithm for the management of contacts. We've had a previous one. We just made the changes into this one. So okay, I'll just go through it anyway. It says the asymptomatic person in contact with a case of a COVID-19. This is the first box. Remember, if you find a contact who has symptoms, you don't. You still classify them, but then you do testing as soon as possible, because now if they have symptoms, it means that now they're turning into a suspected case. So you determine what type of exposure was this from the case definitions that I provided. Is this a casual contact who can be a low risk exposure, or is this a close contact? This will be a high risk exposure. Like I previously said, with the management now, we are saying we should institutionally quarantine everyone who is classified as a contact, regardless of whether they are casual or close contact, so that we maximize on testing and active case finding. So there's active daily monitoring for COVID-19 compatible symptoms, including the fever of any grade, cough, difficulty breathing or fatigue, recording of the temperature, and then preventive measures as usual. So normally you monitor them from the day of exposure for 14 days. If they develop fever before they reach the testing date, you are supposed to test them as soon as possible. But if they don't have any symptoms, then you can wait for day 10 since exposure. Because remember, it takes up to 5 to 14 days of exposure before anybody can show symptoms. So you continue monitoring. Sorry. So you continue monitoring them, and then for I think my slides don't show there at the bottom. It says they're supposed to be where it says laboratory testing. Then if result is positive, this becomes a confirmed case. If the result is negative, then this becomes you can continue monitoring until 14 days after exposure. So if you have a confirmed case from this contact, then you begin the process again of contact tracing and patient management, and then the cycle begins all over again. Next slide. So to assist the district to come up with contact follow-up teams, they can have the following: general nurses, community health nurses, health education assistant, health promotion officers, environmental health officers, psychiatric nurses or social workers, because we have found a lot of stigma and psychological problems that are associated with the cases and their contacts. And then we can also enlist community volunteers to do the daily monitoring. This was very important when we were doing the physically visiting the contacts at their homes in order to do the active daily monitoring. I would like to say we have focal persons in every district that we are in communications with. If we have a contact in, let's say, in Sevilla or in Good Hope, we liaise with the contact tracing person there who is part of the RRT of that district to follow up the contact and then give us the feedback on how the symptom development or the testing would have gone. And then just to add, anybody who's part of the contact tracing team should be reliable, responsible, should gain trust of the community, because if you are doing daily visits to the communities, then you have to maintain trust and respect of that community. So also maintain confidentiality. You should be aware of the local cultures and customs so that they allow you into their homes. Also, everybody who's doing contact tracing should be capacitated on the contact tracing process. Next slide. So when do we do the contact discharge? You can remove the contact from the follow-up list if they've completed their 14 days of follow-up. However, remember not to discharge any contact if they still have pending lab results. You can discharge them after the results are out, even if it's after the 14 days. We discharge contacts from the follow-up list if they become a case. So now they'll be moved to case management to be case listed. You can discharge the contacts if subsequent investigation leads to the person being reclassified as a non-contact, or subsequent investigation leads to the linked case being reclassified as a non-case. Remember to also provide exit certificate for your contacts, because they can stay up to 14 days on quarantine away from the workplaces, so they need to provide evidence of where they have been during those 2 weeks. Next. So in terms of the data that we generate from the contact listing, it should be, remember we have the contact listing form that every district has, but then they should fill up it should be captured into the same version, which is an Excel spreadsheet. And this should be forwarded to the COVID-19 surveillance team at the Ministry of Health and Wellness, and also to the emails as such, which are part of the contact tracing team. So we capture the number of closed and the closed or casual contacts and their locations. We capture the contacts that developed symptoms and became cases, how many contacts were tested, how many contacts were discharged, and if ever there was anyone lost to follow up. Next slide. So with the data, we are able to map where our contacts are, where the majority of our contacts are located at. As you can see, most of for our confirmed cases, because they're in the Gaborone locality, so most of our close contacts, this is only for close contacts, majority of them were mainly located around Gaborone and Greater Gaborone. We've had a few, like one in Maung, one in Letlhakane, a few in Northeast, because we've had a severe case. So that's where you'll see that the case, the contact distribution can then determine where we have to do the active case finding. So if you have data like this, then you are able to inform what form of interventions you can apply to have to really contain this epidemic. Next slide. So how are we trying to improve the contact tracing process? So currently we are migrating our data into an electronic database, into the DHIS2, and then we're going to move to using Excel sheet now to using tablets. So they've promised to issue us the tablets. We have seen them, so we're still waiting for them. And then there's also has been engagement of partners to increase resource capacity in terms of ACHA, Bumi, and the like, so that we can they can complement the contact tracing process. We've also been using the security services to identify contacts whom we have not been able to reach. Also, in order to improve the contact tracing process, we've moved from home quarantine to facility quarantine for better monitoring. Next slide. Yep, and that's the end of my presentation. So together we can make a difference by staying home. As healthcare workers, we cannot stay home, though we could continue to protect the nation. Thank you.
Thank you very much, Dr. Mbenge, for taking us through this important topic. A lot of things have been clarified. We have learned more about the definition of a contact. And also, it's good to know that the approach to both casual and close contacts will be the same from now on. There's been a lot of questions that have been coming in. So I'm happy that our moderators have also been answering those questions in the chat box. So we are really grateful for that. But before I open for questions from the audience, I've been given at least 3 questions that some of the presenters will also answer. I would like to remind you that we have also people online from Ministry of Health that could also respond to some of the questions, especially the operational ones, if they come along. There were 3 questions. One was if there are any contacts that have actually, if there are any cases that have recovered. That question has come many times. And also, there was a need for a clarification on why testing is done on day 10 among contacts and not day 14. So, yeah, I'll probably start with Dr. Palai first on the first one about COVID-19 recovers.
Again, everyone, I think Dr. Howlett actually answered that question. So far, we have 0. I think Ministry of Health and Wellness will report recoveries as they come. But as far as I'm concerned, so far, we have 0. Is there any other question?
Yeah, about the contact.
Okay, on testing of the contacts, we are using the same logic that we are using for people that were placed on mandatory quarantine. Just like I was saying, if you are exposed to a COVID-19 case, it takes up to 5 days for you to develop symptoms and an average of, incubation period of up to 14 days. So if you test anywhere along those days, you are most likely to find cases. I think last week, Dr. Jarvis really answered this question to say by day 10 to 14, between day 10 to 14, most people who develop symptoms would have developed symptoms by then. So it's still the same logic that we follow. Thank you.
Hello. Thank you very much. We would like to open for more questions.
Yes.
Hello, Naga. This is Dr. Masire.
Hello, this is Jibril. Can I?
Yes, Dr. Jibril, I would like to let Dr. Masire come in first. You'll be second.
Okay.
Thank you very much. Do you want to just mute your mic? Okay. Sorry. Excellent presentations, and I think some of the questions that some of us who are not really dealing with this day to day have come up. I think my first question is really to do with the person that looks like is going to be a super spreader. I hear you talking about the extent of what has been done, but I just want to actually find out what happened with this person, because it doesn't look like all the things that you're talking about in terms of quarantining and all of those things happening, because there are lots of friends that he met up with and what if he. So it would be nice to just hear what actually happened in terms of getting to this point that he's infected so many people. With regards to the definitions, or when the contact tracing, you mentioned that you do that 2 days after symptom onset. I know that South Africa is doing 7 days, and I know that you've also mentioned that your guide is based on WHO and the European. We also know that the most infectious time is probably 2 to 3 days before symptoms appear. So to me, I'll be a little worried about using the 2 days before the symptom onset. And then again, in terms of your asymptomatic patients, you've decided you're gonna do the 2 days before. Seeing how that there is potential to really have this thing spread out, shouldn't we be widening that to make it a few more days beyond the 2 days? I was also interested to hear, and I wonder whether our decision to treat both casual and close contact the same is based on the fact that maybe we did not manage some of the people earlier, especially this 27-year-old. So now we a little overreacting, because I'm not quite sure why both the close and the casual contact are treated exactly the same by the healthcare workers with appropriate PPE. So because to me, this can become very unwieldy very quickly in terms of your resources being overridden. So I think I've asked too many, so I'll stop here, and maybe other people will come up with other questions.
So Dr. Mbenge, you might respond to the Prof. Masira's question.
All right. Thank you, Dr. Masira, for that. So for the case, let's see. So for the case definitions, I did say it's 2 days before this. I mean, it's 2 days before the symptoms develop, not after the symptoms develop. And then I also mentioned the risk assessment that we do, especially for the asymptomatic cases. We've gone as far as 7 days to 14 days before the specimen was collected. If you remember the case of the Ramotsa case, and also for the nurse, where we haven't really found out the source of the infection, that's when we really widened our net to look for the contacts and to test them.
So in terms of the symptomatic one, I still, as I said, the South Africans are taking 7 days from the time of the symptom rather than the 2 days. And knowing that you're most infectious 2 to 3 days before the symptoms actually come up. So my question was, why are we, especially if we think that people are falling through the net, why are we restricting ourselves to only 2 days before the symptoms start? Isn't that too restrictive, seeing that South Africa is using 7 days prior to symptom start? So that was my question. I didn't.
Prof. Masira, we really have problems hearing you now. Could you take a look at the audio?
Well, nothing has changed. Can you hear me?
I think the question she's asking is, if people did not get that, it's why we are using the 2 days, not widening it up to 7 days. Like I was saying, as the epidemic evolves, we are always open to changing our case definitions as well. Just the same way like we were changing how we are managing the contacts. We also, as the contact tracing team, like I said, we risk assess case by case to really see if this case can be a potentially very high risk, and we'll go back a little further than the 2 days. We are flexible and not sticking to the 2 days that we found in most of the literatures. Thank you.
Thank you. I think Dr. Jibril also
All right.
comment or question.
Yeah, thank you, Chair. I've been waiting for this presentation, and I'm happy that it went very well. So for me, really, our best bet is contact tracing at this level of the pandemic. And you know, in some countries, in addition to expanded testing, this is what actually worked very well for them, especially South Korea. So if you follow the trajectory in South Korea, it was controlled very nicely. So for me, this is really our best bet. If we do our contact tracing well and we get it right, we're really going to make a lot of difference. My concern really is about the contact tracing team. I'm not really clear as to what. You listed quite a number of categories of staff that can be used, but what is the minimum number that you need in a contact tracing team to do that? I mean, looking at our resources, especially human resources, do we really have that in position? If you're going to list all that as part of the team, as really a complete team, what will be a minimum number of personnel that we'll have in a contact tracing team that you send out to follow a case. So I'm just worried about the resources that we have. But for me, really, like I said, if we do our contact tracing well, we're really in the best position to really make a lot of difference in terms of the pandemic here in Botswana. So thank you very much.
Thank you. It seems like all the questions are on me today. Dr. Palai is safe. So the people that I listed as contact tracers, they're not really like the formation of the team. Is who can you use in the district to do the contact tracing? Then when you are forming teams, you can have teams of 2 to 3 people per team. We've had partners come in to offer their resources like ACHAP, like Bumi. They're offering their community health volunteers, their nurses who can join some of our teams in the district to do the contact tracing. And the most important part, I don't think, is the contact identification. That one is easy. The one that we had a loophole in is the daily monitoring of those contacts. That's why they were falling off the loop, because we're not able to really do the daily monitoring. So now that's where facility quarantine comes in. Then we have somebody who's checking the temperatures, who's doing the monitoring of symptoms daily. Thank you.
Thank you, Dr. Mbenge. We've been now running 5 or 6 minutes longer than the planned time, but if the audience allows, I'll let another 4 or 5 minutes for more questions before we round up.
Chair, this is not a question, this is Dr. Tev. I just want to reflect on contact tracing. Can I go ahead?
Please go ahead and double check your audio, please, because we hear you very poorly.
Okay. How about now?
Very well.
That's better now.
Okay, no problem. Thanks. I think just to be ahead of the game, before we go into the worst situation, we need to learn something, that can help us to do a better contact tracing. Are now currently testing that can help you know who was, within 2 meters of, somebody who has an app, and the other somebody who also has the app, they can connect each other. And this app register actually for 14 days who was, within 2 meters of, the 2 individuals having the same app. Using this now, they are opting to open, their economy, just trusting the system. Now they're going to test now in the next few days. I think it's worthwhile to consider, to learn about this thing and, plan ahead of time also in case, we would be short of having contact tracers and the like. It's just, to throw it there, as food for thought for the program to consider. Thanks. Plan ahead of time also in case, we would be short
Thank you for
of
that comment,
having
Sam.
contact. It's just, to throw it there, as food for thought.
Yes, we're still on for more questions if there are still more.
Sorry, I know I've asked before, but since nobody's asking, I really would like to find out what we're doing about, we've talked about the nurse that we don't actually know the actual case. So what are we actually doing in terms of that? Because that's, to me, is a little unsettling.
Yes, Professor Masiro was asking about the nurse who was caught with COVID and wanted a clarification on how the contact tracing is performed there.
Okay, I'll answer the one on the use of the app. So the Ministry of Health is open to anybody who can bring in any technology to talk to our informatics, the informatics department on what apps or what systems we can use out there to add to the contact tracing process. So in terms of the nurse, that one, case investigations, like when you really don't find the source, you have to deploy an RRT. So case investigations are still ongoing for that. I don't have much to offer, like the final answer to offer on that, but I know that investigations are still ongoing. Thank you.
And if nobody else is asking, so in terms of the 27-year-old potential super spreader, have we been able to contact all those people that he was in contact with and all the other people? Because that to me is also another potential major disaster.
We have been able to identify most of the people that he's been in contact with. Remember, this was somebody who was arriving from a highly affected country who was told to home quarantine. So by the first few days when he arrived into the country, it seems like he was in touch with some of his friends and families. So those people have been contact listed, have been tested, and then this is how this rigorous process that we applied, it's how we came to get the chain. How we were able to unveil this further community transmission that we are seeing right now. Thank you. So not community transmission, so local transmission.
Yeah, and sorry to be monopolizing this. It's just that it's really, this has been dwelling in my head. How are we are on lockdown. How are we then getting hold of these people to come in? These are the contacts. How are they coming in to ensure that they're not exposing other people further? Do we have transport that goes and pick up these people, or do we just ask them to hop into anything to come to us?
Yes, for those of you who did not hear the question, we were having an issue with Prof. Masira's audio, but she was asking how the contacts are being contacted now in light of the lockdown and restricted movement of people.
I'm not sure what you mean. Where are they coming in? As in, how do they get to the facilities? If we are putting them on home quarantine, we offer them transport from our transport department. So I'm not sure if that answers your question.
If they're coming in, if you're asking them to come in, do you go and pick them up?
Yes, ma'am.
Okay, thank you.
Thank you. I think this brings us to the end of today's webinar. I would like to thank both presenters for great work and also for, especially Dr. Mbenge, for assisting us with a lot of answers to burning questions. We like to thank all of the audience for participating and all those who have also participated in making this session interactive by posting questions through the chat box. I would already now like to invite you to the next webinar session, which will be on Thursday. And we will be having Professor Mosepele, who will be giving us COVID-19 updates. So you will receive the invitation through Zoom as before. And thank you all for your time. Stay safe and see you again in 2 days.
Thank you, Doc.
Thank you.
Thank you.
Thank you.
Thank you.
Great job. Bye.
Thank you.